And this led to a survey at the AATS where they asked all the participants, why do you ignore AFib? What's the deal with that? And these were the 4 reasons. They said their safety concerns. They were unsure if it worked, of the advantages. They thought there's a lack of consensus. The societies, their statements, their papers don't tell us what to do. And some said, yeah, I'm just uncomfortable with it. I grew up when the Cox-Maze 3 was all there was, this gigantic cut and sew operation, and that was enough to make me just stop right there. If you look at each one of these, you find that there are definitely today answers about treating AFib or not treating AFib. First, the safety concerns. AFib surgery is safe. There are a whole bunch of papers that show it's safe no matter what you're doing. Here was a paper from Nivad, good friend, asking a question, what if I'm doing an AVR or a cabbage? The addition of a Cox-Maze procedure did not increase morbidity or mortality. What about if I'm doing cabbage or aortic valve replacement? Different study. Is it only true that it's safe in one center versus another? And the answer was no, it's safe everywhere. It was safe in this study as well, meaning no increased risk of adding an ablation. So adding the Maze procedure did not hurt the patient. Ralph Damiano recently looked at the same thing with mitral patients, and he's got another paper coming up that shows this. Adding a Cox-Maze procedure did not increase the procedural risk. So it is definitely safe. And this was the largest study from my friend Vinay Badwar. He looked at the entire US and said, what is the risk of adding surgical ablation? And he found across the US, this is STS database stuff, that performing the ablation was accompanied by improved risk, by a reduction in mortality and stroke. And this is the first study, the largest, so maybe you needed these numbers to show this. This is the first study to show that adding an ablation actually improved patient safety. So that was 87,000 patients. Where did this leave the guidelines in terms of safety? The STS guidelines said adding AF surgery did not increase morbidity or mortality, and the AATS, not to be left behind and even to outdo it, said adding ablation did not increase morbidity and actually improved mortality based on that STS database study. Other surgeons argued, all right, maybe it's safe, but are there advantages? I mean, why bother? I'm here for the cabbage. I'm here for the AVR or mitral valve. What? Just let them live with AFib. Plenty of people have AFib. Well, if we restore sinus rhythm, there are advantages. There are definitely advantages. I mean, the first advantage to doing the procedure is just that. You restore sinus rhythm. If you treat the AFib, they're more likely long-term to have sinus rhythm, which is better. It also improves quality of life. A couple studies showed this. This one study just showed in the red rectangle that people who had a successful ablation were more likely to have a good quality of life. From the same study, left atrial ablation, so not a complete Cox-Maze 4, good quality of life, more common in those who had a left atrial ablation than those who did not. This is one interesting study, but it's been borne out elsewhere. In mitral patients, this is mitral patients. In mitral patients, treating AFib reduces the percent of patients who wind up with late tricuspid regurgitation. So it's good for the right atrium. It's good for your tricuspid valve. The biggest thing to me is freedom from long-term stroke, treating the appendage, doing the ablation, restoring sinus rhythm. You have a greater freedom from stroke if you're treated successfully. And this is yet another study that showed that. And this all translates as well as we can estimate into improved long-term survival if we get a successful ablation and get the patient into sinus rhythm. Now, admittedly, there is no randomized controlled study showing improved survival, but we've got a ton of data showing excellent safety, better restoration of sinus rhythm, greater freedom from stroke and other thromboembolic event, higher quality of life, less tricuspid regurgitation, and it just makes sense that people who have sinus rhythm and are freedom from all these events live longer. And I think this is from Pat McCarthy and Rick Lee. This is the best controlled study. It's a retrospective study, but propensity match, really well controlled to the extent we can, showing that people with treated AFib successfully treated AFib have survival that is as good as if they never had AFib. So this study from Ralph Damiano showing the same thing, successful, emphasis on successful Cox-Maze 4 leads to better long-term survival. So this led to the guidelines saying surgery for AFib improves quality of life, decreases stroke, decreases long-term stroke and TIA. And then the AATS didn't want to go so far as to say anything about survival, but the STS did improve survival. Now the societies actually now do agree, which makes sense that the STS and AATS should agree since it's all of us, all the same people anyway. But this consensus statement from ISMEX, which is a very good paper, pretty quick read, basically says, here are the reasons for concomitant surgical ablations. Here's why you do it. And then here's a broader consensus statement on surgical treatment of AFib and concomitant procedures, which has been endorsed basically by everyone. And therefore, the STS guidelines say concomitant AFib surgery, recommended, 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 and doesn't hurt operative mortality at all, doesn't hurt operative morbidity. ATS, same kind of thing, recommended. Do your ablation. We've got someone who's come into the operating room with AFib, do an ablation. They said improves operative mortality, doesn't affect morbidity, decreases perioperative stroke, improves quality of life, decreases long-term risk, so just do it. And the European societies, same thing. If you come to the OR and you've got AFib, you should get an ablation. Or to put that the other way, we should do an ablation. Still, there are some surgeons who are uncomfortable with it, just don't want to do it. And that gets to the idea that successful surgery is important. As I mentioned, when Nivad came to visit me, he picked up some nuances that my team and I weren't paying as much attention to. And the difference between successful and unsuccessful AFib surgery is for the patient a difference in freedom from stroke, for the patient a difference in freedom from death, difference in survival, but for the surgeon, the difference between success and failure is often just really paying attention, staying away from that atrial pacemaker complex, making sure you get a complete lesion for every lesion, in particular for the lesions that go to the annulus, mitral and tricuspid. So it's not that you've got to be the next Dent and Cooley to get this right. It's just like anything else we do. You've got to know how to do it and then execute appropriately. And this gets to the idea of training. You know, no one just goes out and does a new operation without ever seeing one or being proctored on one. It's worth making sure that you've got, if you're new to it, a senior partner. If you're new to a particular part of it, you know, maybe go to one of these weekend courses, which are a lot of fun. But just make sure that you know how to do it, because we are all 100% capable of doing this right. If you can do a Lima to LAD, which we all can, Lima to LAD is way harder than this operation. It's microsurgery, and there's a lot riding on it. So this is far easier. So how did this wind up working? In terms of education, in 2009, same figure we saw before, 15% of AFib was being treated. 2012, it doubled, 30%. 2015, 50%. Seems like we're stuck around 50 to 60%. But I think patients also are getting savvy to this. Patients are saying, hey, can you do something for my AFib? And the answer from all of us is, yes, we can. So the summary of this is in 2020, there's got to be a good reason not to do an ablation in someone having concomitant surgery, because it really is the standard of care. Now, what would be a good reason not to do an ablation? Well, look, if you're doing a third-time redo triple valve in an 85-year-old with a low EF, I mean, first you have to ask, why am I doing this operation? Can I actually get the patient to survive? But maybe you say, in that person, if I can, I'll treat the appendage, but 20 minutes in that person might actually make a difference. But duration of AFib isn't a reason. If you've got someone who's been in AFib for 15 years, don't say it's never going to work. It very well might work. 15 years of AFib, maybe you've got a 50, 60% chance of getting rid of AFib, getting that person off Coumadin or a DOAC. So it's definitely worth doing it, almost always.